Dr. Snigdha Chitnis, and I'm the category manager here at Medvarsity. I'm talking with Dr. Sai Praveen Haranath on a topic which he's very passionate about, and it's tele ICU, and it's a topic which has become very important with the current pandemic situation. So I think let's start with that, with the fact that it's a global scenario where the number of hospital beds or ICU far outnumber the number of critical care specialists available, and so it's just a handful of critical care specialists for a huge population. It's a global scenario. So how does tele ICU help bridge this gap?
Sure, that's a good question, Snigdha. So I'm a pulmonary and critical care doctor at Apollo Hospitals in Hyderabad, and a lot of what I do is remote intensive care. So I do it for places around India and also overseas, the United States. And one of the things we've realized is that, as you rightly said, the number of ICU beds, it's probably about 70 or 90,000 now around the entire country. And the number of critical care specialists is probably about 10,000 who are in the registered roles of some of the large critical care organizations in India. And you hit the nail on the head in terms of it's a global problem, not just in India, in the United States, many other countries. A lot of people in rural areas have zero access to critical care. So they really don't have either the expertise or sometimes even the technology or the beds that are required. And one of the ways to bridge this gap has been to kind of remotely assist them. And in the COVID pandemic, we've seen the power of telemedicine. We've really seen how we can actually really leapfrog and really upgrade the technology using very simple devices sometimes to treat patients who could be located anywhere in the world. Now, what we've seen is that critical care really involves a lot of cognitive thinking. A lot of it is just not just about hands-on doing. A lot of it is about thinking and doing the correct approach for a patient, the right diagnosis, the right treatment options. And the advice can come from anywhere. So you could have somebody who doesn't have the experience of a senior critical care doctor, but if they have the basics done right, if they know when to intubate a patient, who has respiratory failure, who needs management of septic shock, how do you handle trauma, how do you handle an emergent heart attack, when do you give thrombolysis? I mean, these are all questions which anybody can answer with basic medical training. The advanced level care can be given remotely. We can, as an expert, guide them in ventilator management. We can look at the ventilator, look at the alarms, look at the graphics and say, you know what, maybe you should adjust the tidal volume down, for example. And as you know, in conditions like ARDS, it's important to use low tidal volume ventilation. And many studies have shown that using tele ICU, you can actually enforce quality measures on a 24/7 basis for every patient. Now, the analogy is with aviation. So when you fly in a plane, when you take off and you land, you really don't know who the pilot was. I mean, he introduces himself, but you don't know who he was. You don't know who loaded the fuel in the plane. You have no idea who did the maintenance. In fact, you have no idea who's the air traffic controller down there. And in a flight from, say, Hyderabad to Delhi, you're kind of going through two air traffic controllers who don't know who the people in the plane are. But you land safely. So healthcare should become like that, and especially critical care, because it's advanced technology. You're using advanced knowledge, but it's more or less the same for most patients. So you can actually teach people to do it right, and you can guide them on the spot. So you have several teachable moments, not just for doctors, but for nurses too, because you're looking at them and telling them, hey, you should keep the head of the bed elevated at 30 because that saves lives. You can look at the glucose and say you need to control it to 180 or so because that saves lives, and give antibiotics early, and that saves lives. So it's important to realize that tele ICU is not all about the technology. It's a lot about the communication part. It's about the teaching part. And the structure of a tele ICU is usually you have a command center, and from the command center you have other ICUs which are located anywhere in the world, which could be in a rural area, for example. And in the command center, you have nurses and doctors and technologists who are helping monitor everything. You have the feed of the cardiac rhythms, the blood pressure, the pulse, the oxygen level all coming into a dashboard type setting. And you can have automated alerts which tell you that this patient is actually not doing well, focus on them. So there's many ways to kind of do this. And then once you've done that, you can do like a evaluation of any ICU patient. You camera in on the patient, talk to the family, talk to the patient, find out what the issue is, talk to the doctor or the nurse at the bedside over there and ask them, okay, what have you done so far? What are the next steps? What is the plan for the day? And many places in India, for example, have the doctor running the outpatient and the hospital and the ICU, and they sometimes live on top of the hospital. That's the normal way things happen. And for them, they hardly get any rest. Say at 2 in the morning, somebody with a 40-year-old male has a fever of 104. If the tele ICU is connected, we can actually guide the nurse and the duty doctor there, or if there's no doctor, even we can guide them and understand what's wrong. Is it sepsis setting in? Is this a fever from malaria? Is it dengue? We can even evaluate and see is this a side effect of some drug. We can tell them, why don't you give them acetaminophen? Why don't you get blood cultures, get a sputum culture, initiate antibiotics if you need, and then we can kind of wake the doctor up and say, hey, you know what, we have done all this, is there anything else you want? So there's a lot of efficiencies that come in because of tele ICU, and there's a lot of things you can do remotely, which we have been doing for over a decade now.